speaker is Dr. Bhuvanesh Agarwal, who is the President and CEO of Sysmax Inostics in Hamburg. He's a medical doctor with a specialization in internal medicine, clinical pharmacology, and also pharmacology and toxicology. After serving at the Free University of Berlin for nearly 15 years, he joined a major pharmaceutical and diagnostic company. He had multiple prominent roles in this company, and the last role being chairman and managing director of the South Asia sub-region. So he was involved in developing a beta blocker for heart failure and several cardiac markers, as well as personalized medicine. He then co-founded a molecular diagnostic startup in Singapore in 2012, which developed the first NGS-based CE-IVD test, oncology and infectious diseases. His presentation today is on liquid biopsy and its application in medicine, sharing and experience. So I would like to request the audience to please scan the QR code to answer a brief survey. Over to you, Dr. Bhuvanesh.
Good afternoon, Professor Umarani. Thank you very much for your very kind words of introduction. I would like to thank the organizers as well as Pantai Hospital for the opportunity to present some thoughts on liquid biopsy, which is a very difficult task after the previous presentation. Can you see my screen, please?
Yes.
Oh, thank you very much. So I would like to briefly speak about liquid biopsy. And liquid biopsy, just like tissue biopsy is a tissue sample, liquid biopsy is basically a blood sample. And with all the tumor elements swimming in it, it could be circulating free DNA, a part of which is circulating tumor DNA, ctDNA, which will be the focus of this talk. It could be mRNA, it could be circulating tumor cells, extracellular vesicles, metabolites, microRNA, and whatever else. And there are various ways to process these elements. So my focus will be on circulating tumor DNA. Why do we use circulating tumor DNA? What are the benefits of that? First of all, there's a very high concordance with tissue samples, especially of those cancers which shed in the blood. This happens to be the case, fortunately, for most of the cancers, including the head and neck cancers that we had just heard about. It's minimally invasive and convenient because, as we know, in many cases, for example, in lung cancer, tissue sample can be difficult to obtain. In about 30% of the cases, we don't get it. And therefore, it's also much cheaper because all you need is 10 milliliters of blood. It gives you a holistic tumor information because a tissue sample may not be representative because of sampling error, or it may not represent tumor heterogeneity from metastasis. Also, you have a faster turnaround time. You can get results generally within a week. And with tissue samples, you take about 2 to 3 weeks. You can do repeat sampling, which is of course not possible with biopsies, to assess progress and recurrence. And you get real-time information because circulating tumor DNA has a half-life of about 2 hours. So it is also therefore found entry into many guidelines. For example, here we have the NCC practice guidelines for non-small cell lung cancer, a very recent version, which says that it can be used in specific circumstances. For example, if we cannot get an invasive tissue sample or if there's insufficient material. But there's also a cautioning point, and that is that though it has a very high specificity, but significantly compromised sensitivity with up to 30% false negative rate. It's also found in other guidelines, like the Japanese guidelines, as you can see here, where first of all, it is recommended for the optimal perioperative chemotherapy, but also to monitor therapeutic effects of anti-EGFR, so TKI therapy, but also of other molecular targeted drugs. Also, the NCI colon and rectal anal task force white paper recommends a number of areas for clinical application in colorectal cancers, including detection of minimal residual disease, management of patients, monitoring responses, and tracking clonal dynamics. So why is it not used more broadly? Well, there are a few challenges associated with it. One of them is that it's only a small part of the DNA which is swimming in the blood. So about 99% of the DNA is normal, it's wild type. And only a small part is tumor DNA, and this amount, the fraction of DNA molecules to total DNA molecule, is what we call mutant allele fraction. Now, most technologies, as you can see on the right, PCR, NGS, etc., can get around 1% detection. If you optimize it, you can improve it by maybe about 50%. But actually, with the current technologies that I would like to present, beaming and SafeSeq, you can actually improve it by a further order of magnitude. Now, why is this important? If you look at data on patients with metastatic cancer, we find that about 40 to 50%, whether it is colorectal cancer, non-small cell lung cancer, or breast cancer, have mutant allele fractions which are below 1%. So as you saw in the guidelines, the sensitivity was lacking by about 30%, and the reason is because we miss these low mutant allele fractions. That's important when you do liquid biopsy, that you take a technology which is extremely sensitive. Now, if you look at the course of tumor DNA levels, of course, there's a time when it is developing. At the time of diagnosis, you have the maximum. You do your treatment stratification, you treat a patient, it goes down, hopefully either to 0 levels or to a small level, which you can just detect, which is called minimal residual disease, before you have recurrence and tumor and levels grow. Now, generally, in this phase, it could or could not be detectable, but you want to detect it as early as possible when there's a recurrence. Now, the problem with imaging is it is a rather late method. And so with liquid biopsy, you can detect recurrences up to 1 year earlier than the current standard of care, which is imaging. So with this, you can, by detecting earlier, you can also manage the patient better. This is some data to show various methods. And as you can see, with a target allele or mutant allele frequency of about 0.06%, there's a 97% confidence in detecting this level with the technology SafeSeq, which has been devised by the Johns Hopkins University in the US and is introduced into the market by Sysmex recently as PSS. So, and this is the way the kit looks like. There are 5 kits available, and I will briefly talk about that together with the software. And the 5 kits are colorectal cancer, melanoma, non-small cell lung cancer, thyroid cancer, and breast cancer. Now, this is a very sensitive method. This has been compared with a digital PCR technology called beaming, which was also developed at Johns Hopkins. And as it shows in the various mutations and genes, you actually have 100% positive agreement. We have data from breast cancer, we have data from non-small cell lung cancer, as well as from AML patients. So there are a number of questions that one has to answer after laying some of these foundations. First of all, how well is the correlation with tissue biopsy? There are a number of studies, especially in colorectal cancer, which shows that there's about a 90% agreement with tissue samples. So there's a very high correlation between liquid biopsy and tissue samples. So this SafeSeq technology has a number of benefits. First of all, it's highly sensitive, so you can actually detect molecules in a sample, so up to 7 mutant molecules with a 95% confidence. You have a high flexibility of between 2 and 6 samples a run. You have a high laboratory efficiency because you can combine several types of samples in one run. It's a standardized workflow with a high reproducibility. You get results within 2 days, and the software is extremely convenient. So where should you use circulating tumor DNA in solid cancers? So principally, in my opinion, there are 6 possible uses of a diagnostic test. One is predisposition screening for diagnosis, so that we know what further steps to take, prognosis to decide on management strategy, for treatment stratification, so that we know how to differentially treat it, for minimal residual disease, and for recurrence. In my personal opinion, for predisposition screening, it's doable, but there's always a question around cost-benefit ratio, and it's not an area where I feel liquid biopsy has the best usage. Also in diagnosis, we generally use tissue samples, but of course in those areas where we cannot get tissue, or where we have other issues because a patient is not suited, like non-small cell lung cancer or colorectal and breast cancer, there are indications that it could be useful. Above all, it's interesting to use it for prognosis to decide on the management strategy, because the quantity and types of mutations in various cancers have been shown to be beneficial. For treatment stratification, for example, to find out which mutations, copy number variations, or fusions may be there. Again, there's evidence in a number of cancers. For minimal residual disease, to decide possibly on a cancer holiday. Again, here the evidence is somewhat small, and a major use of it would be for recurrence, so that we can optimize treatment. And again, there's a lot of evidence, and I will try to share some of this evidence, both with studies, but also individual cases, because that sometimes illustrates it even clearer. When we talk about early breast cancer diagnosis, in this study done in Spain, there were 29 patients with BIRADS 4C5, and the patients, 10 out of 29 patients had mutations detected in plasma. The concordance with tissue was low. However, there were 3 patients in which TP53 mutations and 1 PIK3CA mutation was detected in plasma that were not detected in matched tissue. So it can help you to find mutations which you are not able to find in tissue. And actually, looking at them in more detail, we found that many of these patients actually had mutant allele fractions of below 1%. And that is why it's important to have a very sensitive test. This is a case study of a patient who actually had a melanoma. And what happened is that, the patient progressed through immune therapy. The pathology report showed no BRAF mutation from the skin biopsy. But the CT, the circulating tumor DNA revealed that there was a BRAF V600E mutation. Based on this, the patient was given BRAF and MEK inhibition, and there was an anti-tumor response in this patient. There's another example of the usefulness of liquid biopsy is, again, a patient, a 60-year-old male, whose CT scan revealed a pancreatic lesion. The fine needle aspiration only yielded a few cells, which were insufficient for molecular testing, but histopathology did reveal a melanoma. So liquid biopsy with the beaming method was used for BRAF and NRAS testing, and 3 days later, an NRAS mutation was found. MEK inhibitor was administered, and 1 month later, the CT imaging showed a clear shrinking of the tumor, and further management of the patient was in a trial for a PD-1 inhibitor, and the patient was able to attain durable response. ctDNA actually can also be used in the neoadjuvant setting. In this case, this is a study with 37 plasma samples collected from 17 breast cancer patients over 3 time points. So neoadjuvant treatment, during the treatment, post-neoadjuvant treatment, but pre-surgery. And what was found was that in the 11 patients who had a pathological complete response, showed no detectable ctDNA, and those who did have not have that, of them, 3 actually showed detectable circulating tumor DNA response at the surgery time point, showing that ctDNA can be a good indicator of residual disease. Also, the clearance of circulating tumor DNA in cancer patients can be a good predictor of outcome. So in this study, with a tyrosine kinase inhibitor, we looked at the clearance of mutations at 6 weeks and found that those patients who had a clearance of mutations at 6 weeks had a median PFS of 10 months or 11 months, whereas those which did have detectable mutations actually only had a PFS of 4.2 months. So clearance of mutations in circulating tumor DNA is an important prognostic marker. But it can also predate some of the developments of lesions. So for example, in this case, here in purple, you see the liver lesion, and you see the ctDNA detected with an ultrasensitive method here in blue. And what you see is that at day 200, you start seeing an increase in the ctDNA levels, whereas the lesion size was still constant, and it preceded basically liver lesion growth by almost 5 months. Here's a case of a patient with non-small cell lung cancer who was being treated with immunotherapy. And here you see that the ctDNA response, there was no ctDNA detected. And as you can see, over 4 years, the patient has had a durable response to treatment. There's a very nice study by Jeannie T and colleagues from Australia to see whether postoperative cDNA can identify recurrence in high-risk stage 2 colon cancer patients. And because we still don't know how to treat patients with adjuvant chemotherapy. In this study, they had 230 patients from 13 hospitals, and they wanted to examine postoperative blood samples to identify direct evidence of residual disease in the form of ctDNA. What they found is that if patients were negative for postoperative ctDNA, you can see that they had a recurrence-free survival over 4 years in a very high, with a very high likelihood, whereas if they were post-operative cDNA positive, they had a much poorer outcome, whether this was in clinically low risk or high risk patients. They also looked at locally advanced rectal cancer, and again, they found similarly that detection of ctDNA pre-treatment, post-chemotherapy, and in post-surgery plasma samples were much worse if it was detected versus when it was not detected. So I would like to briefly summarize there are a number of areas for which circulating tumor DNA can be useful. In patients where biopsies are not possible or tissue samples are not possible for diagnosis, but especially for prognosis, treatment stratification, for detection of minimal residual disease, and to detect recurrence early, which will help us to manage our patients better. So the conclusions are, it's a useful marker showing lots of promise in many areas of cancer diagnostics. There's increasing evidence of clinical benefit due to simplicity and increasing standardization, but also because of faster turnaround time, because we can get results within 2 days. High sensitivity is extremely important for disease monitoring. The mutant allele fraction detection should be much lower than 0.1%. It's also increasingly entering guidelines, and there are a number of indications for it: dynamic monitoring of tumor response, identification of resistance mutations, detection of minimal residual disease, but also to select optimal therapy approaches. With that, I would like to thank you very much for your kind attention. And if there are any questions, I'll be more than happy to try to answer them. Thank you very much.
Thank you, Dr. Bhuvanesh Agarwal, for such an excellent, informative talk. And I would like to invite questions from the audience. Okay, there are some questions here already. Okay, from Dr. Noraisha Sharon. What are the types of cancers that will be less likely detected using the liquid biopsy?
So what are the most likely cancers? The most likely are non-small cell lung cancer, colorectal cancer, breast cancer, skin cancer, which is not so common in Asia, but also head and neck cancer, leukemias. So in the most common cancers, we do have evidence. There are some cancers where shedding rates are low, and those are the cancers where we would not use it. But most of the cancers that we have investigated so far, including, by the way, biliary cancers, pancreatic cancers, they seem to show a high shedding rate. So most of the cancers so far have been found to be useful. Low shedding rate would be areas such as thyroid cancer, where the usage is not yet really well established.
Thank you. There's one more question from Ms. Noor Soleha, IMR. So I'll just read out the question. The question is about the ctDNA itself. From her reading, she says that the half-life of ctDNA is about 16 minutes to 2.5 hours. So meaning that we need to perform the test immediately after sampling. So is it possible to preserve the sample overnight and perform the test the next day?
It is. There are several methods to stabilize the DNA. There are certain sampling tubes, for example, Streck tubes, in which it is not only possible to actually stabilize it, but even to send it to labs. It is stable in Streck tubes, for example, of between 5 and 7 days, even under Malaysian conditions.
Okay, that's nice to hear. Just a gentle reminder to the participants, please scan the QR code and answer the survey. That is, the QR code is here. So my question, Dr. Bhuvanesh, what about all the, is there like false positive or false negative, the kit that you mentioned just now? So what is the prevalence of that,
So the question is, what is actually the problem with a very sensitive method? And I can say this because I was also involved in the development of troponin T and other markers, is what is the gold standard against which we compare it? Because we never know the truth. For us, tissue sample is actually the gold standard. Yes. If we take it according to that, then it would be around 90% sensitivity and specificity if you have an ultra-sensitive method. If you don't have a sensitive method, then your specificity will be high, but the sensitivity will go down, as we saw in the US NCCN non-small cell lung cancer guidelines. So for me, ideally, it should be in the 90-90 range. And the reason is because if a method is more sensitive, then it may be less specific according to our current gold standard.
All right, there's one more question. This will be the last question. So this question is from Dr. Jeffrey Susilo. Okay. Okay, she's wondering if mutational analysis on ctDNA is currently possible for the panels of genes shown, or can we also detect other associated gene mutations or determine tumor mutational burden to predict response to immune checkpoint inhibitors like the NSCLC?
Yes, it is. So the method that we use is an ultra-sensitive method, which means it's narrow but deep. But there are also other liquid biopsy tests which are very broad and not as sensitive. My personal approach as a doctor would be, if I have a new patient, I would initially take the broad approach so that I don't miss any of the mutations, because the narrow panel would only have a few genes. Once I know which one it is, then I would look at the ultra deep sequencing level. So yes, it's possible not only to do mutations, but there are also copy number variations. For example, in some cases we do HER2 copy number variations or c-Met copy number variations. It's also possible to do tumor mutational burden. There are tests with non-small cell lung cancer which can do TMBs. It really depends on what your requirement is, and based on that, I would choose which panel to take.
Thank you, Dr. Bhuvanesh. Thank you for answering patiently all the questions. I'm sure there are more questions, so kindly answer, if possible, in the chat box. So once again, I would like to thank you for your excellent informative talk, Dr. Bhuvanesh. So that ends or concludes our session. And
thank you, Professor Omarani, and thank you to all of you. Thank you very much.
Thank you. And now I shall hand over the floor to the MCs. Thank you.